Hey, everybody, welcome back to the Outcomes Rocket. Today, I have the privilege of having Dr. John Sargent on the podcast again. He is the co-founder of BroadReach Group, and he's a renowned innovator in the space dedicated to advancing fourth industrial revolution technologies to promote global health equity. Dr. Sargent actively champions private sector involvement in health development through public-private partnerships. So excited to have him back on the Outcomes Rocket. John, thanks for joining me.
Thank you so much, and congratulations on all the success you've had with Outcomes Rocket since I think we spoke probably 4 years ago.
It's been a while, man. No,
Yeah,
I really appreciate that. It was sort of before the pandemic. You guys were very much focused on really like chronic diseases and in really tough spots. So if you can just kind of catch up the listeners on
yeah.
what you guys were doing, and then let's talk about what you're up to now.
What our whole focus, so I founded BroadReach with my best friend from medical school, and we hit our 20-year anniversary this year. And
Amazing.
we are social entrepreneurs. So our whole focus in life is to make sure people who are especially underserved people have access to healthcare. And so we started off in Africa because we started around HIV. So about 20 years ago, the world was waking up to the HIV pandemic. And the countries in Africa, like Botswana, South Africa, were going to be devastated. And so what we were able to do was to start putting together large scale population health management programs, combining people, process, and technology to partner with governments, NGOs, anybody running an HIV or tuberculosis or malaria program to do better. So as an example, one of our biggest customers is USAID through the U.S. government, and they gave us money early on to work with the government of South Africa to help monitor and manage about 1,000 government hospitals and clinics, their performance, training doctors and nurses with HIV, how to take care of HIV patients, tuberculosis patients, and then eventually we developed a technology platform to help monitor and manage everything that was going on, including running predictive analytics to identify which patients are likely to stop taking medicines, intervene, that sort of thing. So it's been an interesting ride, and that's still the core of our work. We've worked in about 25 different countries around the world doing these large scale population health type programs.
It's at scale, right? I mean, you guys are doing these big time, and you and I had a chance to connect before the episode started, and so you guys have
Yep.
shifted some of these learnings to the U.S. to help us understand
Yes.
what you're doing here.
My co-founder Ernest and I are both Americans, and I think when COVID hit, and obviously it changed how everybody thought about health and healthcare and thought about lots of different things. But we were really closely watching what was happening in the U.S., and I think it just really shone a light on the disparities that are in the U.S. healthcare system. And so I think the question we asked ourselves at the time was, look, we've been working in super resource poor settings, places where you've got, like one doctor per, 20,000 patients, where, governments are spending $30 per patient per year, massive SDOH issues. And we've developed the technology platform Vantage and lots of approaches and techniques to help these patients. And the question was, could we take some of those learnings? Could we take some of those capabilities and apply them into the US? And, I think we've really had some interesting work, and we're just really starting to grow work in the SDOH area. So let me give you an example. One of the big sort of groups we've been working with are community oncologists in the US. And community oncologists tend to get a lot of patients who have SDOH issues. And so they will, for example, all of a sudden miss their chemotherapy because they lost their job or they lost their car, or they have housing insecurity, or they just have bad outcomes because they're not eating properly. And so in the US, a lot of times what happens is you only find out this problem after the patient has an issue. And so, the question we asked was, okay, well, we have this really sophisticated Vantage technology. Has managed close to 3 million patients on antiretroviral therapy in Africa. Could we take this and could we help providers do a couple things? Number one, proactively identify those patients who are likely going to have issues. And after they speak with those patients, put in based on screening tools, what their issues are: housing security, food security, and then use our technology. Because I think the thing we learned in Africa was creating next best actions. Because in a really resource poor setting, people aren't going to look at beautiful visualizations and draw the dots and say, oh, the next three things I need to do on Monday morning are this. So we've developed a lot of next best action. So what happens is once the patient is screened, the system automatically creates a social care plan for the patient based on everything that's been created. It automatically tracks referrals, it automatically tracks all the things that you need to do for that patient. So the life cycle of that patient completely automates it so that the patient navigator, the nurse, the social worker doesn't need to have post-it notes and Excel spreadsheets to keep lists of who they need to follow up on. So it's been really interesting. And I think a couple of really, we've actually exceeded all our expectations. So this group that we've been working with in Houston, as an example, oncology consultants, um, there were a couple things that really happened in the first 6 weeks. The first was that we identified immediately a couple populations within their patient population that were having problems. And we use an ePro tool called Healthy Days that was developed by the CDC. And we noticed that in the Vietnamese population and the Black American population, they had incredibly low ePro scores. And so the system, based on that, surfaced these folks up immediately to the case managers and the social workers, and these issues resolved. And we found in a matter of like 4 to 6 weeks, the Black population and the Vietnamese population had a 60% and a 40% improvement overall. And then we found also that their social workers, their patient navigators are spending 5 to 8 hours less per week in administrative work. So I think this is really positive, and yeah, we're excited about the future. We're in discussions with lots of different organizations about taking this solution we've created on our Vantage platform, which we call Social Health 360, and really taking it to the next level.
So in this particular situation with the Vietnamese and the Black populations, what was the gap? Like, what and how is it resolved?
The beauty is we actually have all this information, so we can go patient by patient and understand what the issues are. But what we've seen is that those who have low ePro scores tend to have uh, either an issue with food or housing. Those tend to be the two biggest things. And so um, I think in this particular population, that was sort of a prevalent issue in the Vietnamese and the Black American populations. And I think a lot, again, this is just the reality of providers, and providers are overworked, burned out. They don't catch things until it becomes a problem. And so these were problems. And the only reason we caught them is that we were doing ePros and reaching out to the patients. If that hadn't been done in a typical provider setting, that just sort of gets lost. So I think by actively doing that, we're able to identify those problems, then fix them. I mean, the goal is to never identify the problem with ePro. The goal is to identify the problem when the patient first walks in the door, and then
Sure.
prevent it from becoming a problem, which we've been able to do for the sort of like the next cohort of patients.
No, it sounds really promising. And what are some of the other directions you think that this could take?
We heard during COVID and before, like a lot of the literature shows that social determinants of health, really are horrible for overall health outcomes. Patients cost more if SDOH issues aren't addressed. And we sort of known all these things. The problem was that for most providers, there was never any money available to help them do this. And a lot of times these social determinants of health issues, the providers are only seeing them after decades of other issues that weren't solved and fixed. And so the challenge always had been that, they try to do the best that they can with the limited resources they have. What's changed very recently is that the Medicare is now starting to reimburse. Medicare fee for service beginning in January is going to start reimbursing um, for SDOH or social care services. And then Medicare Advantage, I think, should be following in 2025. We've also had some state Medicaid plans doing that. Some of the Blues plans have been doing that. So I think we're skating to where the puck is going. And I think ultimately, in the next 2 to 3 years, this will become standard that providers will get reimbursed for the social care that they're doing. That completely changes the game. Then the next question is, okay, well, it's great. I can get reimbursed, but my staff are burned out. That there's not enough nurses, there's not enough social workers. What do I do? And so I think the next piece of that equation that we have to solve is what we're doing right now. Social Health 360 is using AI to try to get rid of the administrative burden, do the heavy lifting around all the coordination, all the things that need to be done so that whoever's dealing with the patient can operate at the top of their license and really hopefully take a lot of the drudgery off and let that person, whether it's a nurse or social worker or community healthcare worker, really focus on the patient and deal with the patient. So I think the next 3 years are going to be really exciting around the social care side. And I think it'll make a big big difference as we move into more value-based care settings. It'll, I think, ultimately improve patient outcomes and decrease total cost of care.
Ultimately, aligning the incentives to make sure that you're able to deliver this type of care. And it seems like the time is now.
I think COVID really shone a light on that. And there's a lot of experimentation going on. CMMI has been doing lots of really interesting programs in oncology and kidney care, in primary care. So I think the data is coming, and we do need a little bit more data. I mean, it'd be nice to show that these types of interventions, ultimately are ROI positive and do have a big impact on the quality of care.
Well, look, I think totally they do. And with time, we'll prove that. And especially with the work that you and the team at BroadReach are up to. If for anybody listening to this sees what you see, right? They see where it's going and they want to do something about it. What's the best way for them to get in touch with you and start a conversation? Are you open to that type of thing?
So, our whole ethos is partnership. We start out in Africa. The bulk of our employees, our offices are still in Africa. There's a small group of us in the US. So we want to partner. We want to find the right groups because it's not our ambition to grow a massive organization in the US. So I think, the best way to contact me is, on my email, jsargent@brhc.com. And we're open to any type of partnership. Either it's, partnerships around distribution channels, working together where we really need folks on the ground to help with the change management implementation of these of Social Health 360, looking to integrate. Also, ultimately, you can't take social care separate from clinical care. You have to integrate it. So I think also
Yes.
a lot of partnerships integrating with EMRs, clinical care platforms, et cetera.
Dr. John Sargent here with us, folks, making a big difference in social determinants of health, making sure we're not avoiding the very much necessary touch points. So John, can't thank you enough for sharing what you do with us, and definitely looking forward to following you guys here as the year unfolds.
Great. Thank you so much, Saul. Thanks for thinking of us and inviting us back again. And I look forward to hopefully having a lot of really cool updates the next time we speak.
Yeah, looking forward to that as well. Thanks, John.